I'm Dr. Raphael Schiffmann. I'm a professor at Texas Christian University in Fort Worth, in Texas, USA. And I'll be speaking about some aspects of the importance of um, diagnosis early of Fabry disease. Reducing diagnostic delay is crucial because any therapy for the disease is efficacious to the maximum when it's initiated early in the course of the disease rather than late, when irreversible organ changes have already occurred. And also early diagnosis of an individual affected makes possible the subsequent cascade of family diagnosis that can help to effectively treat other members of the family who are affected by Fabry disease. The biggest challenge for early diagnosis is the fact that almost all clinical manifestations of Fabry disease are non-specific in nature. The problem is particularly severe in those with later onset Fabry disease who do not have physical characteristics of Fabry disease, such as the skin angiokeratoma or corneal verticillata, and often uh, present as single organ involvement. For example, an ischemic stroke secondary to Fabry disease uh, presents clinically and from the neuroimaging point of view, just like a stroke from any other cause. The progressive renal insufficiency has the same characteristics as, for example, diabetic nephropathy. And host uh, cardiac abnormalities of Fabry disease, such as hypertrophic cardiomyopathy, cardiac fibrosis, or arrhythmias, present like the same complications resulting from a common heart disease etiology, including other hereditary conditions. Similarly, the pain and sensory deficiency of the small fiber neuropathy of Fabry disease, it presents itself like a small fiber neuropathy from any other cause. And so that the big challenge is in general the lack of knowledge and diagnostic persistence, or even the curiosity of members of uh, the medical teams. The most atypical symptoms occur in children who develop consequences of the small fiber neuropathy of Fabry disease. They present with pain in the hands and feet, particularly uh, during febrile episodes, and in combination with poor sweating, have as a result poor heat and exercise tolerance. Not attributing such symptoms to primary behavioral abnormalities is very important. Such symptoms are also common in adults who complain of either continuous or episodic pain in general, and neurological examination, and even neurophysiological testing are negative. It is again important not to falsely think of these as psychological or psychiatric conditions. Gastrointestinal symptoms such as diarrhea of or frequent vomiting should not be overlooked at all ages. In theory, newborn screening, either by measuring alpha galactosidase A activity or by DNA sequencing, is the most efficacious method since it evaluates virtually the whole population over time. Screening individuals with kidney disease or proteinuria of unknown cause or hypertrophic cardio or hypertrophic left ventricular abnormality of unknown etiology or even ischemic stroke in the young have shown about zero point 0.5 to 1% of individuals screened to be affected by Fabry disease. The big recent advance in the existence of is the existence of gene panels for such groups that results in diagnosing the correct disorder, even if not suspected clinically. Family screening that results from the identification of an affected member of the family is crucial to allow diagnosis and early treatment of other affected members of the family. This also facilitates genetic counseling, which explains to the family the mode of genetic transmission of the disease, i.e., who is certainly affected or certainly unaffected, and who is at risk and has to be evaluated and tested. That is, children of an affected woman may or may not be affected by Fabry disease, while older male children of an affected male uh, will uh, will not inherit the relevant genetic variant, while all the female offsprings will. So it may surprise you, but any busy clinician who comes across an individual with clinical manifestations that he or she cannot r- readily explain has to take a few seconds and check with Google or a site called Open Evidence, all free, and quickly input those clinical characteristics uh, of the patient in front of them. In most cases, the correct diagnosis will appear in less than half a second. Not doing that is, in my view, a dereliction of duty. In fact, some of the patients I encountered diagnosed themselves that way when their physicians were unable to. I like to emphasize something regarding the diagnosis of Fabry disease. In general, in males, the main way to diagnose is to measure the alpha galactosidase activity in peripheral blood white cells. It will be close to zero in those with the classic form of the disease and below 30% of mean normal of that laboratory in late onset Fabry disease patients. In females, however, gene sequencing identifies heterozygotes, and of course, we know of a lot of variants uh, of the GLA gene that are uh, pathogenic. Important to note that computer analysis of a variant can be misleading. A variant may be called by the computer as damaging or probably damaging, but in fact is associated with enzyme activity that is below 100% of mean normal, but higher than the disease threshold of 30% of mean normal in that laboratory, which signifies that variant is likely to be benign.
Hello, I'm Dawn Laney. I'm a genetic counselor and the current director of the Genetic Clinical Trial Center. I also am the program leader of the Emory Lysosomal Storage Disease Center. We're going to talk about the role of GLA variants in the pathogenesis of Fabry disease and the identification of clinically relevant GLA variants to guide diagnosis, treatment, and management planning. One of the most important things to know when you're sitting in front of a testing report is what test was ordered and what results are you looking at. Because you may be looking at a report that came unexpectedly and told you your patient has a change or a variant in the GLA gene that was from a broad test, like a panel test or a genome, or it was looking at just a carrier test that somebody had while they were pregnant. There's several categories of results you can get. One of the most common things you'll receive is a pathogenic variant. And that one will say, okay, this patient has a change in the gene that's disease causing. But what can be a little tricky is a disease causing variant in the GLA gene can cause something that's as severe as classic Fabry disease, where it starts in childhood with the burning pain in the hands and feet and progresses over time to end organ damage. Or you could be looking at a benign variant, a variant that's more of a polymorphism that doesn't cause any problems theoretically, but may need a little more investigation. Or another very common result is a variant of uncertain or unknown significance, or what we like to call VUSs. VUSs are the most complicated thing you can get because it doesn't immediately tell you what you should tell your patient. If you get a variant of uncertain significance in the GLA gene, it may mean your patient has a pathogenic variant, but it's unique to this one family. The way that labs decide whether a variant is pathogenic, which is disease causing, or benign, which is not, or somewhere in the middle, is by using all the data available about that variant out in the literature. And then they'll predict based on the type of change that it causes to the formation of the GLA enzyme. Whew, it's a lot, right? But what you need to do is say, okay, we've got a variant of uncertain significance. Is this one that's been described in the literature? If it's not, then you really need to look closely at the patient themselves. What symptoms do they have? And then there's additional testing you can do to learn about that. And then you need to look at the family history. Also, databases can be very useful in this. I think it's important to know that you can always reach out to an expert in Fabry disease, whether in the lab or in the clinic. When you think about this, the first line of defense is looking at your patient. And what you'll do is look at the symptoms that patient may have, and then you look at who else might be at risk in the family and what symptoms they might have. However, if you found your variant through newborn screening, your patient probably doesn't have anything going on in the health department. And so suddenly you're faced with a look at the family with a mother who may be very young, with grandparents who are a little bit older but may not have the full bloom of symptoms depending on which type of variant you're looking at. And that's where looking in the literature can be very helpful. One tricky thing about the literature is, though, in the beginning, all variants in GLA, as long as they weren't considered 100% benign, were kind of considered disease causing in the beginning. So you need to look at the more recent literature. And when you're looking at a database, such as ClinVar, which is where different laboratories report their different variants, you're really going to want to look at when the data came and what's the quality of the source of the data. Often the next thing they're going to talk to you about is getting an alpha galactosidase A enzyme level, usually in leukocytes, sometimes in plasma, all from the blood. And this way, if you test through a lab that's experienced with enzyme levels, it can give you another piece of information about somebody's status when they have a variant of uncertain significance. Now, there's a little tricky thing here too. When you have a woman with Fabry disease, her alpha galactosidase A enzyme level can be completely normal, even if she has the most severe classic form of Fabry disease. And that's most likely due to X inactivation. When we started working with patients with Fabry disease, particularly as we were thinking about treatment and what we can watch change as quickly as possible when somebody begins a disease-specific therapy, we looked at this biomarker called globotriacylceramide, also known as GL3 or GB3. That was pretty good because we saw with treatment, when you had a high level of GL3 or GB3, it should go down. But we learned that, in fact, there's a better way of looking at things. And this other biomarker that's found in the blood, and you could test in the urine, is called lyso GB3 or lyso-GL3. This one seems to be a little bit tougher to get to decrease when you start therapy and seems to be a better biomarker for telling us where somebody falls in the spectrum of disease severity. It gives us a clue. Could this be someone who's going to have classic early onset Fabry disease? Is it somebody that's in the middle that may have some features of classic and more later onset organ specific symptoms? Or is it somebody who we expect to have a slightly later onset, which is still life impacting and definitely earlier than what we'd expect in the general population to see the symptoms they're having with heart and kidney and other parts of their body? The one thing we need to think about, though, again, with that X inactivation, women may have normal or lower levels of lyso-GL3 or lyso-GB3, even though they have disease symptoms. It just means that sometimes biomarkers can't be the best possible way to figure out if a woman has disease. So then we go back to the drawing board, look at family history, see if we can't find a man in their family line who has that same GLA variant, and then we can test them for enzyme levels. We look at their lyso levels. Now, again, if you're looking at a newborn, you will have the ability most often to have that little man who's there and available for you to do their testing levels. The only drawback is over the first year of life, lyso-GL3 rises. But from some work that has been done over the past longitudinal years, we're able to see how they separate out if you've got a newborn or a young child with classic Fabry disease, if they've got later onset or somewhere in the middle. Now, in some cases, we're looking at a very controversial variant. I think a great example of that is our PA143T variant, which pops up a lot, particularly in newborn screening or somebody's doing exome or a genome for an organ-specific issue. And in that particular disease, you get a variety of people, some with elevated lyso, some with absolutely no elevated lyso. And again, sometimes it can be a little complicated, and feel free to phone an expert. Lyso also seems to be something that causes inflammation or more inflammation and scarring in the body. So when we think about lyso, we think about it being a particularly big biomarker that we would like to get rid of as much as possible in the blood because of its pathogenic effects on the body. So when we think about patients who are expected not to have symptoms of Fabry disease, we want their lyso levels to be normal or near normal. However, there are some things out there that will make your lyso level go up. There was a great study from Raphael Schiffmann that found that lyso levels can be elevated in people with severe heart disease and some other different findings that he was looking at. So we have to be a little cautious in interpreting that. So we want to make sure somebody has a variant in the GLA gene, and if they have elevated lyso, that gives us a clue. Except, and here's the exception, women with Fabry disease. Women with Fabry disease may have normal levels of lyso-GB3 or lyso-GL3, just as they may have normal levels of alpha-galactosidase enzyme, even when they have severe disease. Genetic counseling in a perfect world would happen before you have your test drawn and your samples sent away. And the reason I say that is because we can explain to patients ahead of time through genetic counseling what the possible results might be. And we can give a little clue like, oh, because you have these specific symptoms, we feel you might have Fabry disease for this reason. Or, hey, we're going to do this giant panel of genes, and there's a chance something can come back that not just has implications for your children, but you as well. And boy, wouldn't that be great. But in the vast majority of times, we end up with a genetic testing report that looks at GLA in your hand much before the patients even understand what the testing was. So in the back end, genetic counseling is critical because you're spending time basically changing somebody's worldview. If this is about a child, if this is about a woman, if it's about a man, in every case, you're taking their identity, their knowledge about themselves, and saying, guess what? You have a chronic disease now, and you need to do some therapies, or we're going to have over time massive health issues for you. That is just the most difficult and life-changing news you could give to somebody. When you think about uncertain variants, it's even harder because you have to tell the people, we don't exactly know. But the best thing you can follow it up with is, but we know exactly what we're going to do. Because we do. Even with all our like wishy-washy going back and forth on what we do with variants of uncertain significance, if that were to be a pathogenic variant causing classic Fabry disease, we know exactly what we'd do. We'd look at them from head to toe, we'd start them on treatment as soon as possible, and we'd be there with them every step of the way to make sure they understand what's happening and why certain things are really important for their overall health, and why, in fact, they do need to think about treatment of their Fabry disease. So I would say in a perfect world, study up a little bit on Fabry disease, watch some great educational videos like these that help you understand what people might be asking or thinking about. When you've got a level of uncertainty, be comfortable with that, be able to say, I don't know exactly how this is going to impact your family, but here's what we're going to do next, because people love a plan. one of the easiest and best things you can do is look for CME, CEU workshops that are available to keep you up to date on things that have been reclassified or how we think about things a little bit differently. Because the world of Fabry disease is changing rapidly. Back when I first started, at first we thought women did not have Fabry disease. They were just carriers. Well, that really quickly got turned on its head. So when we think about what's the next thing that's changing, there's two things that I feel like in Fabry disease are really important to understand. The first is that a variant that may be a variant of uncertain significance today may be found to be just as severely classic as a more severe form, or it could be benign. So if you are able to look at databases such as Fabry, genotype, phenotype, GenFin is what they call it, if you can keep an eye on CLIN variant, there's some other databases like Dr. Sakuraba has a great database. It's fabry-database.org. And there's a couple of other databases that'll pop up and be there for a little while and then they'll go away again. It's okay. You can always figure out what's going on with that. You can always talk to the laboratory. You're welcome to call a laboratory and say, hey, any changes in this variant of uncertain events that you reported to my family? Or you may be calling the lab after you do your enzyme testing and your lyso-Gb3 and your family history to say, hey, I think I've got enough evidence for you to reclassify this lab. Are you able to recontact others? There's work in place that is trying to find a more systematic way to notify healthcare providers when a variant of uncertain significance has been reclassified, but they're not live yet, and there's only a lab or two that does that automatically. So in some cases, when you see your patient annually, that's a great time to check into that variant, call the lab, do a little quick Google search, do a little literature search, see if your variant has popped up with anything new. The other thing is feel free to, again, reach out to a Fabry disease specialist in your area. They may have a wide body of knowledge that has just come up. For example, right now I know there's great work going on in deep phenotyping in the A143T variant that hopefully will find some modifiers over time that might give providers a little bit more insight into that. Over time, pathogenic variants may be better understood. The other thing to look at is certain variants we know are responsive to what we call chaperone therapy. It's just one of the different arsenals in treating Fabry disease. And there's a specific website that looks at whether a variant is amenable or not. And if there's changes to that, that website should change and there should be some information in the literature. So I would say keep your ears open. If you are not a specialist in Fabry disease, it's okay. You can just do a quick Google search here and there and make sure your sources are reliable. But sometimes the easiest thing to do is phone a friend and ask them if there's anything new with that variant. Because if something has become a little bit more common, they're able to tell you what they're thinking and how you should investigate it further, even if you've already done it once. Maybe there's something else, some other new clue that you should learn.
Hello, I am Dr. Goker-Alpan, and I'm the founder and the executive director of Lysosomal and Rare Disorders Research and Treatment Center, which is a nonprofit organization with a vision to provide high-quality care for individuals with rare disorders, but with main focus on lysosomal diseases. Today, I'll be discussing treatment options for patients with Fabry disease and the correlation with GLA mutations with the clinical presentation and how these guide therapeutic and monitoring decisions. Fabry disease is a heterogeneous disorder with a wide variability across the organ involvement, and patients, even siblings that carry the same mutation, may have different or varying presentations. So treatment for Fabry disease is individualized, that is taken into consideration the age of onset, the disease burden, the progression, whether there are complications at the time when you evaluate a patient, and also the family history also is very important when, how, and what to do with the treatment-wise. Enzyme replacement therapy is the standard of care for patients with Fabry disease, male and female, regardless of the GLA mutation type. There are currently 2 approved therapies in US, and there is an additional therapy, enzyme replacement therapy, that is available for patients in Europe. The other alternative option is the pharmacological chaperone therapy, or migalastat, that is available both patients in US and Europe. Currently, there are other therapies that are coming in the pipeline, small molecule therapies as substrate reduction or gene therapies that are still being in early phases of the trials. When we take the genetic changes or the disease-causing mutations, they only not help us, a physician, to decide on the therapy. When we see the GLA mutations, so the most common mutations are in the GLA gene are the missense mutations, which are or can be amenable to the pharmacological chaperone therapy. But some missense mutations are also associated with classic Fabry disease. And depending on how the patient is impacted, and the patient has significant disease load. I can give an example. Recently, I've seen a patient, actually as a family, they both had missense mutations. And this, I'm saying mutations because there were two mutations on the X chromosome, and we had it tested. They were both amenable to the pharmacological chaperone therapy, but we chose a few family members to be on the PCT, migalastat, whereas the proband, or the patient that came initially to the medical attention, was significantly impacted with the disease. He was already in renal failure on dialysis, so the choice for this patient was for the ERT. So if I need to review the GLA variants, that includes missense, nonsense, frameshift, and other splice site variants. Missense mutations, while they are the most common and may be amenable to migalastat, because they result in a misfolded enzyme, some of them may not be amenable. Whereas the nonsense, frameshift, and large deletions, they are typically associated with very little or close to zero enzymatic activity, and they are not amenable to the pharmacological chaperone therapy. There are splice site mutations, and they may have variable effects, and they are usually treated with enzyme replacement therapy, and only single proven amenable missense mutations are eligible for the chaperone therapy with migalastat. I think this is very important when you see and start evaluating a patient with Fabry disease who is new to your practice, because not all the mutations predict the phenotype accurately. And there are multiple factors that we can list as genetic, epigenetic, environmental, and then that can change the presentation and course of the disease. Genotypes should be weighed in conjunction with the clinical context, such as the age of the patient, age of onset of the disease. The patient may present to you later in adult life, like the patient that I discussed previously, who is very far into the disease and was being misdiagnosed, or your patient can be a teenage individual that either got diagnosed through family screening, or now actually we are diagnosing the patients earlier and earlier, who may have symptoms or who may not have symptoms, and you make your decision, if your GLA variant is indicating a severe phenotype, and if there is significant family history. I do have some families that have very significant, death in multiple male patients, or female patients from the same family, severe kidney and or stroke history. So basically, you may want to actually treat these patients earlier than later. As I said, the genotypes should be weighed with the clinical context, such as the organ involvement and the disease burden and the family history. And the genotype is not alone is sufficient to therapeutic decisions. So we evaluate each patient individually. That includes medical and other factors such as social, and also the patient desires, and whether ERT is the right choice for the family. Or the other issue is that there are immune hypersensitivity reactions, or the antibody formation that is commonly seen with the enzyme replacement therapy. So if a patient is coming to you and who has an amenable mutation and had such experiences with the ERT, you may consider switching the patient to another option if there are amenable mutations to pharmacological chaperone therapy. So the practical steps, obviously, there is looking into the GLA variant, and then decide whether this variant is amenable to migalastat therapy. So if you review the GLA variants, the in the human gene mutation database, the majority of them are missense mutations. That is hypothetically the pharmacological chaperone therapy or migalastat should be effective. The other variants, such as frame shift, nonsense mutations that produce almost null enzymatic activity that are not going to be amenable in theory to the pharmacological chaperone therapy. So basically, these patients should be automatically considered for enzyme replacement therapy. So splicing substitutions, unless proven otherwise, also they are mostly treated with the enzyme replacement therapy. Therefore, those patients probably are not going to be candidates for the pharmacological chaperone therapy. But obviously, that the databases for amenability should be checked. And how do we optimize therapy for patients with Fabry disease using genotype and also take in consideration the phenotype? So hypothetically, we have a patient that is young who is coming to your practice with some preference to oral therapy. So first, we assess obviously the GLA variant, and we decide whether this is associated with a classic phenotype versus a non-classic phenotype, and then whether the variant is an amenable mutation. So once a consideration is made for an oral pharmacological chaperone therapy, obviously we have to assess a few things. So first is the patient compliance and whether the patient shows interest in oral therapy and whether patient can be reliable. Because we are going to be assessing the in vivo or clinical amenability. So when we look at the clinical amenability, obviously the disease onset, disease severity, which organ systems are involved, and whether there are chronic complications are present. In my practice, we also follow the enzyme levels, given that the patient is taking the drug every other day on an empty stomach, and then we try to actually match the time points, and then we, after we assure the in vivo amenability, which is you see an enhancement in the residual enzymatic activity, then you assess whether there is clinical amenability, which means that whether there is progression in the organ systems or there are chronic complications are encountered in such patient to decide such treatment. Migalastat is the right treatment for the patient. Actually, this is my favorite subject, talking about the clinical biomarkers that aid us to monitor the patients with Fabry disease. Obviously, Fabry disease is an adult onset and chronic disorder, and the disease outcomes, unfortunately, are not experienced within a short duration of time. So when we need to do some therapeutic decisions, we use what is called biomarkers. The first one is lyso-Gb3 or globotriazyl sphingosine, which is the deacylated form or the lysosomal form of the stored substrate, Gb3. And for the past decade, we have been successfully using this biomarker first as a diagnostic in the strict terms is not a diagnostic biomarker for Fabry disease, because in other disorders, lyso-Gb3 can be increased to a certain extent, but is never as high as in a patient with Fabry disease. So when we actually get the lyso-Gb3 levels first for a patient with Fabry disease, and when we see that it is significantly elevated, then we consider the classical, obvious, the phenotype. And the second thing is lyso-Gb3 is a pharmacodynamic biomarker, which means that it does change and responds to dose changes. And also it does change to assess the efficacy of the treatment, such as, when you have a significant amount of ADAs or immune hypersensitivity reactions, and you're questioning whether there is an efficacy issue for the ERT. And if your lyso-Gb3 is going up, then you consider this actually as an efficacy issue. And then you would like to make therapeutic decisions, whether it's the GLA variant is amenable to pharmacological chaperone therapy or migalastat. You may consider switching the patient if there is an efficacy issue. And how lyso-Gb3 is utilized, we follow lyso-Gb3 every 6 months. Some practices do yearly, or when you actually consider or did a therapeutic change, such a patient is switched from ERT to migalastat or migalastat to ERT, obviously you need to follow the lyso-Gb3 levels more frequently. The other biomarkers are the imaging biomarkers, that cardiac imaging that we started using, cardiac MRI with gadolinium enhancement. Actually, we are utilizing is more often. The reason is there is a significant difference in the males and females, how the cardiac system is involved. In males with Fabry disease, there is the hypertrophy of the heart, which is concentric, and it progresses with the disease. As opposed to females, the posterior wall may be involved, and or they may be scarring without the significant hypertrophy. So the only way to assess this accurately is going to be using the cardiac imaging or cardiac MRI with the contrast to assess whether there is scarring and how, what percentage of scarring. And also cardiac imaging helps us to assess the therapeutic response. How is recommended is following the heart involvement regularly, about 2-year interval. We do yearly in patients, in adult patients, and for pediatric population, we decide on the frequency, whether there is involvement or there is family history related to the cardiac involvement. So the brain imaging is using MRI, in some instances CT scan, which is actually is shorter duration of time, and whether the patient has any issues that is actually precluding the MRI. So we do brain imaging is every 3 years, or more frequently when there is a clinical need. What you can see in the brain imaging is obviously white matter changes and or the vascular abnormalities or vascular ectasias, especially vertebral arteries. And the last one that I need to mention is not the least, obviously the proteinuria or microalbuminuria or albuminuria in these patients. So we follow these patients diligently for the spillage of protein. It is, even though it is at least annually, we follow at least every 6 months, and we assess whether there is a need for anti-proteinuric treatment. The reason is if you don't control proteinuria, then the other system progression, such as the heart, could be more fast. So first and foremost, we need to keep in mind that treatment for Fabry disease is individualized. So each patient is taken as one, and then we make the decision as we go by. But we need to take into consideration the understanding, the interplay between the genotype and the phenotype that allows us better individualized therapy and select the right modality of therapy and track the progression more effectively. As the last take-home message, I am emphasizing that the GLA genotype is an integral part of the Fabry disease diagnosis and care when coupled with clinical phenotype, patient history, and emerging biomarkers that enables the precision medicine in patients with Fabry disease. Thank you.